This is the Man Up Podcast, a doctor's guide to men's health. Each week on our podcast, we interview the top specialists of the field on various topics in men's health. You have questions that you are too afraid to ask. We have the answers. This week, our episode is titled Sex After Cancer Treatment. I'm Dr. Kevin Chun. I'm joined as always with my co-host, Dr. Justin Dubin. Justin, it's been a while, man. How you doing?
I'm doing good. Started working. It's exciting time.
Wait, why don't you tell the listeners, where can they find you?
I'm practicing in Memorial Healthcare System in South Florida. I have offices in Aventura, Boca Raton, as well as Pembroke Pines. So I'm all over South Florida. If you need help, feel free to reach out.
Exciting.
That's what I'm here for. I'm excited. And Kevin, you're starting this week?
I'm starting next Monday. I'm joining a private practice group, Advanced Urology, here in the Los Angeles area. We got offices in Westchester all the way down to Redondo Beach, but, I cover the whole LA area. So, just look me up. And, it's exciting times for, me and you, Justin, right? We're kind of like, all the knowledge, all the training that we've gotten, we're going to apply it and try to help out patients best of our abilities, right?
It's very surreal. I mean, it's one of those things we've been in school and never had our real jobs. And here I'm 34,
right.
a little bit older than me. And we're starting in the real world for the first time. So it's very, very exciting. But also we're a bi-coastal podcast now.
Oh, yeah.
And we're also taking men's health coast to coast. So it's pretty cool.
Love it. On that note, of men's health, Justin, we're actually, there's two awarenesses going on this month. And I think this episode is super timely that will address both those, things that are going on, right?
Yeah, and we are very aware this month. And there's so many awareness campaigns, but this one is actually really, really cool. So, September is actually Sexual Health Awareness Month, right, which is very important for both men and women. And also it is Prostate Cancer Awareness Month. So the topic of today is sex after cancer. And for our patients, a lot of that times that involves prostate cancer. So it is really the perfect time for this episode to come out because we're going to be talking about sex, but for patients who have prostate cancer, other kinds of cancer, and our focus is really going to be pelvic cancers, right, colon cancer, bladder cancer, is what we're going to be talking about with Dr. Mulhall, who is absolutely, one of the top guys in the world coming out of Sloan.
He's a thought leader in our field. He truly is a thought leader. Yeah.
And people worry, we fix your cancer, but can you have sex? Can you live that life after cancer? And that's what we're here to talk to about today.
I mean, Justin, you and I, we see our patients and we have for us, it's, sex is an important part of life, right? For each person. And, when you get a cancer diagnosis, sometimes some of these things aren't really kind of running in your head. And, after treatment, you start seeing that there could have been some possible side effects secondary to it. But that's why we like to, we wanted to get all this information out, just kind of, what you need to know going into treatment and even afterwards, and that knowing that there are people out there that can help you to still achieve the sex life that you want.
You're 100% right. And the thing that makes it so interesting for us is you're right. People, they go see the doctor and they're like, I need my life saved. The most important thing is we need to make sure I'm here for the next 5-10 years.
Yeah.
And, the way that things are, the technology that we have and the advances we've made in medicine, fortunately, most people are going to be around. You're going to get treated. But then during the treatment, like you said, after the treatment, there's potential for things to get compromised. And your sexual function and wellness is one of those things. And people after that, when they're not thinking about it, they're now alive and they're thinking, I want to be with my partner. I want to enjoy life. And that's where we come into play, right? Because, living 10 years after cancer, not living the way you want, that for some people, that may not be worth it. But they need to know that there are options for your sexual health as well as, your overall health. And that's where we come in. And this is why this topic is so important.
100% spot on. And we see all of it. We treat prostate cancer and we see a lot of patients afterwards. And, we have an understanding, and that's why we want to try to get this information out. So, you know what, I think we should jump into the interview. What do you say, Justin?
All right, let's do it. All right, so we are very lucky to be joined by Dr. Mulhall, who
Very
is
honored.
the director of male, very honored, who is the director of male sexual and reproductive medicine at Memorial Sloan Kettering Cancer Center in New York. Thank you so much for joining us today.
My pleasure, and I thank you for doing what you're doing for our patients.
Thank you. Yeah, so I think today what we're going to be doing is we're going to be discussing the topic of sex after cancer treatment, specifically pelvic treatment and pelvic surgery mostly. And that for us as urologists, as obviously you're at Sloan Kettering, big, the #1 cancer facility, right, pretty much. We deal with a lot of patients who come in after they have pelvic treatment for cancer, whether it's prostate cancer, colon cancer, bladder cancer, just to name a few. And they have a lot of sexual potential. Well, they potentially could have sexual dysfunction afterwards. And so this is actually one of the most common reasons patients see us for erectile dysfunction. And my first question is really, why can these surgeries, pelvic surgeries, actually potentially cause erectile dysfunction? How does this happen?
Yeah. So let's focus on the kind of stereotypical pelvic surgery, which is radical prostatectomy for prostate cancer, which is kind of the model, right? So during that operation, if you're a patient, I want you to think about an orange that sits in a box, and that orange is wrapped in saran wrap. And buried in that saran wrap are microfibers, optical cables. And those cables, those tiny microscopic fibers, are your nerves. To get that orange out of the box, you have to split the saran wrap, which is the tissue which is outside of the prostate. And then you take the prostate out. The maneuvers that are used to extract the prostate put pressure and trauma, percussion injury, traction injury on the nerves. And those nerves are super sensitive, and when they're pulled and pushed, they go to sleep. And for most men, they go to sleep for 9 to 12 months, and it takes another 9 to 12 months to wake up fully. That's why most men have erectile dysfunction, and it takes 1 to 2 years for erections to recover properly. There are other causes, but that's the genesis of the problem.
Gotcha, Dr. Mulhall. That was a beautiful way of describing a prostatectomy. Now, real quickly, so a lot of patients come, to me, and they're like, "Look, what exactly? How many people are going to actually, like, how common is it to develop ED after the prostatectomy? Am I going to be, one of ones not to get it?"
Yeah. I would say it depends on what you mean by ED. If you mean at least temporary problems, I would say that's 100%. Now remember, the low point in erectile function after radical prostatectomy is about 4 months. So you'll hear, as you know, surgeons stand up and say, "Well, I take the catheter out and the patient has an erection the next day." That's not the time point to define erectile function. So it's usually 3 to 4 months after surgery before there's a low point in erectile machinery function, right? So we know, for example, from published literature, it happens to be our literature published, is that when you get men who are functioning in the very early stages after surgery, that about 25 to 40% of them will have a dip over the first 3 to 4 months. And then you're in a plateau phase for many, many months. And usually the nerves start waking up between 10 to 14 months, and they don't maximize the recovery until 18 to 24 months. So the first thing that patients need to know, you've got to be patient. Okay, you've got to be patient. And one of the travesties, and you've trained in urology programs, and I'm sure you've heard this, but one of the travesties in urologic oncology is the surgeon who says to the patient, "Your erections should be fine in a few months." And when the erections aren't fine, and the patient gets depressed and upset and worried. When you're much better off, I believe, saying to a patient, it's going to take probably at least 12, maybe 18, possibly 24 months before you get back to the best function possible.
Right. And I think that's an excellent point when you're saying best function possible, because I think a lot of people don't understand that, when we're counseling patients and they're asking about how their erections are going to be after surgery, I think it's the idea of setting those expectations where, you're not going to have better erections than when you came from before surgery. The best we can do is to get you where you were before. So if you were using something like Cialis, you were using something like Viagra before, the best you can really hope for is getting back to that point. Is that correct?
Very interesting concept, because what you're referring to there is called back to baseline, right? And there's very little literature on back to baseline. In fact, there are 2 papers in the literature on back to baseline. And if you take men and you say you use questionnaires, so these scoring systems to assess erectile function, and if you take men under 60 years of age, 25% will get back to their baseline without the use of a medication. But with the use of a medication, 50%. They're under 60 now, 59 versus 45. Okay. If you take men over 60 years of age, those numbers are 16% get back to baseline with medication, but only 4% without a medication. So this is a very, very age-dependent process. So getting back to baseline is actually quite tough, right? We have these prediction models, as you guys know, they're called nomograms. And when we use our nomogram looking at preoperative factors and nerve-sparing status that predict recovery, if you take a 40-year-old man with perfect erection function before surgery, with perfect nerve sparing, who's no other medical problems associated with ED, most of those men will have a significant drop, with the average drop being 6 points in the EF domain score. So that's a significant hit, right? So everyone takes a hit. The older you are, the poorer erectile function, the worse your erectile function is going into surgery, the more medical problems you have, the worse off you'll do. And I think you guys know that, at the meetings recently, we've been talking a lot about diabetes, the presence of sleep apnea, the presence of low testosterone before surgery worsens the erection function recovery.
Yeah, so just to recap for the listeners out there, so, what Dr. Mulhall is saying, so a lot of these preoperative factors, these are things that you're going to have to kind of think about, because that will probably play a little bit of a role in, outlining the risk for, getting ED after surgery. Now, Dr. Mulhall,
setting expectations.
Exactly.
For sure. Yeah.
So Dr. Mulhall, are there ways before surgery in which men can reduce the chances of getting erectile dysfunction?
The first and most important thing is to speak to your surgeon and say how important this is in your life, right? Declaration of interest. One of the most important factors in getting realistic expectations. Patients think that the surgeon will tell them everything they need to hear, when the surgeon, he or she, will tell them what the surgeon thinks they need to hear. Okay? So it's very important that you communicate to the surgeon, this is really important for me, right? My wife is 20 years younger. We're very sexually active. This is really important. Okay? And in that sense, the surgeon will be bound to do the best nerve sparing possible, right? Now, remember, there are many reasons why nerves are injured. One is technical skill. The other is cancer cure, right? So sometimes the nerves cannot be saved completely. But declaration of interest will be the first thing. The second thing is choosing a good surgeon, right? Okay, it's the $1 million question, right? Patients say, how do I choose a good surgeon? And, radical prostatectomy or radical cystoprostatectomy for bladder cancer is essentially neurosurgery, right? It's essentially neurosurgery.
Yeah.
And what's the feature of neurosurgeons? They're usually pretty patient people sitting around there under the microscope taking their time. Likewise for prostatectomy. You really need a patient surgeon to take their time, to do good nerve sparing, to avoid using cautery, the means by which we reduce bleeding, right? If you're going in there with cautery and burning things all around the nerves, that's not good for the nerves. So choosing a good surgeon volume is important, okay? Somebody who's experienced, not just somebody who's experienced, but somebody who's technically proficient. You can be 4, 5, 6 years out and be more technically proficient, but somebody who's been in the business 30 years. If you're just a good surgeon. We know that as surgeons, there are some surgeons who are just technically gifted and some surgeons who are less so. So choosing the right surgeon, choosing the surgeon with good outcomes, high volume, knowing somebody is doing this all the time. We know from the surgery we do, the more you do, the better you get at it. So there's some things, but just looping back to what we talked about low testosterone, sleep apnea, diabetes, etc. I mean, there are medical conditions that if you don't have that serious level prostate cancer, so high grade Gleason 8, 9, 10, if you don't have it's outside of the prostate, where you want to be doing your prostatectomy in a reasonably expeditious fashion, it might be worthwhile thinking. And this is one of our pushes now with surgeons, trying to why don't we postpone the surgery for 3 to 4 months, and let's work on controlling your diabetes and your sleep apnea and your medical conditions that are known to be associated with erection problems.
That's a great point. And I also think that you bring up the point of we're treating cancer first. And at the end of the day, sometimes, like you said, the Gleason score, or there's other more aggressive cancers where you may not be able to spare the nerves. And that's kind of part of setting expectations as well, because, saving your sexual life is important, but saving your actual life is the primary goal when we're talking about oncological care. But obviously there's right. No, but quality of life is very, very important, and that's where we all come in. And, as men's health, sexual health doctors, we recognize, having a life worth living is important. And we want to if sexual health is part of that experience for you, we want to maximize that. And I think that kind of leads into the next question here. The concept of penile rehabilitation, it's really a term that we use for treating erectile dysfunction in men after they've had surgery like a prostatectomy. Now, what does that mean? And really, what does that entail for most men?
So if you're a patient, I want you to think of your penis like your biceps, right? And if you took your arm and you put your arm into a plaster cast for a year and you didn't move it and you took the cast off, you know very well that your biceps will have undergone atrophy, right? The same thing happens in the penis, except in the penis if you're not getting erections, right? So it's like your penis is in a cast for a year, except in the penis, that atrophy is permanent. Now, it's technically not atrophy. As you guys know, it's technically collagen deposition. So the muscle turns from nice, spongy tissue into gnarly tissue. The brand new sponge you bought at Bed Bath & Beyond, right? You use it every day for a year, right? And it looks gnarly.
That's great. I have that in my head.
That's what you have to think of happening. So then when that muscle degenerates, that's permanent, right? And that muscle degeneration leads to a condition called venous leak, right? When that muscle degenerates, the valve inside the penis no longer works. The penis is like a bicycle tire, right? 2 hoses, left and right artery, bringing in blood. And there's a valve mechanism that closes and keeps blood inside. And that valve is controlled by the muscle. When that muscle undergoes atrophy, then the valve becomes leaky. Blood flows in, but it's flying out on the other side. And that's the mechanism by which people get left with severe ED after prostatectomy, or men who need long-term penis injections, or even men who don't respond to penis injections.
So, Dr. Mulhall, you just touched upon injections. So, for our listeners out there, what are the treatment options for men with ED after a prostate surgery?
So the treatment options are the same as they would be for any patient, except getting back to what you asked a little earlier, Justin, I didn't really answer. It was the concept of rehabilitation. Can we do things to protect the muscle? One is low-dose Viagra, Cialis, Levitra, or Stendra. Those kind of drugs, they're called PDE5 inhibitors. There's not a massive amount of good data to show this, but it makes a lot of sense. If you look at what these drugs, the Viagra drugs, do, they protect the lining of our blood vessels, and the penis is a big blood vessel, right? So the tissue is called the endothelium, and these pills protect the endothelium. Okay, so why wouldn't you use it when most people can get these drugs for very, very small amount of money? There was a time before you guys were really in the business. There was a time when these pills were $60 a pill, right? But now you can get 20 milligrams of sildenafil for 40 cents, right? So why wouldn't we do that, right? So that to me is the minor component of rehab. The major component, Kevin, as you were alluding to earlier on, is the concept of getting erections, right? Most people after prostatectomy are going to need to use penis injections, right? So if you look at our data at Memorial, only 15% of men get a penetration hardness erection with a maximum dose pill within the first 3 months after surgery. 15%. So 85% of men, right off the bat, they come in to see me 6 weeks after surgery, pills are not working, straight to penis injection therapy.
Okay. Now, if they don't want to do penis injection therapy, there is another option, of course, and that is the penile implant. Now, there's other options too. You have the suppository, you have VED, you have all these other devices as well. Now, for people interested in something like the penile implant, and we could have a million talks on the penile implant in itself, how often, someone's very eager, they're not satisfied with oral medications, they're not satisfied, they don't want to inject themselves with it, which is understandable for a lot of people. How long do they have to wait after pelvic surgery to get something like the penile implant?
That's an excellent question. If you were following the Twitter sphere over the weekend, you probably saw some discussion about this, right? Okay.
Yes.
So here's my philosophy on implant. I do plenty of implants. It's what I do for a living. I want to give every man the best possible chance of getting back to either natural erections or a pill response. I already told you that it takes a year to 2 years to really understand if that's ever going to happen. Okay?
Right.
So it's very unlikely I'm going to suggest penile implant surgery within the first year after surgery. The exception to that will be somebody who had predominantly non-nerve sparing surgery, where the surgeon for cancer control said the nerves are gone, right? And then the patients have hopeless response to pills and maybe even hopeless response to injections early on. The only thing that's going to help those men is penile implant surgery. But outside of that, we try to wait at least a year and we see how they're doing and see if the nerves are waking up. Are the pills starting to work? Is the pill response getting better? If you start getting to 18 plus months and things are doing poorly, then I believe penile implant surgery is on the cards for those patients.
All right. Awesome. So Dr. Mulhall, just to kind of wrap up the ED aspect of the talk, I actually want to, in a lot of your papers, you talk about, post-prostatectomy, there's, a lot of why me and Justin do this show, a lot of guys, they're afraid to just talk about or accept that they have ED. They go through depression. That's a big element of it. I just want to see if you could kind of expand on that just a little bit.
Yeah, so I have the distinct advantage of working with Chris Nelson, right? Chris Nelson is the psychologist who works alongside me. Chris has researched extensively mental health in the prostate cancer population, particularly after treatment. So it's a new sex, right? It's the new sex, right? The whole concept of you take a 65-year-old man with a 65-year-old wife, they've been having sex for 35 years together, and then all of a sudden, sex is no longer intercourse-based, at least temporarily, right? Unless they're using injection therapy. So I'm very big on discussing sexual outer course with men and discuss the concept of non-intercourse-based intimacy. And this is really important because if you take a 65-year-old woman and if she goes a year plus, 18 months, 2 years plus without having intercourse, a proportion of those women will accommodate to a non-intercourse-based lifestyle. So it's in your best interest as a man to start learning how to have outer course to maintain intimacy while we're waiting for your erection machinery to recover. We use Chris very freely in our practice if somebody is having real struggles, and we do have men who have real struggles with this. But I think, again, if you go back to realistic expectations and the concept of patience, and you can give men hope. Your nerves were saved. You good function before surgery. Let's give it a little while, establish non-intercourse-based intimacy, and then things will recover. Many men will respond very favorably.
I think that's so important that penetrative sex is what we all think about as guys. It is just what we think about when we think about sex. But, penetrative sex is not the only kind of sex. And I think, putting that in people's head is great.
In the Western world, guys, sex is very linear, right? Get hard, penetrate, have an orgasm, and fall asleep, right? That's not what most women are looking for, right? If you speak, this. If you speak to the partners of the men, I'm glad my husband's alive, but not alone don't we have intercourse anymore. But he doesn't cuddle me. Yeah. We don't spoon in bed. He doesn't put his arm around me on the couch anymore. These are really important things for men to think about, right? They've had sex for 35 years. They've never talked about sex.
So true. It's such a great point. All right, let's move on to, because one part, when we think about, all these surgeries, most people are thinking about erectile dysfunction. But there's other aspects that are compromised during the sexual, experience. And, one of those things is not being able to ejaculate. And we call this dry orgasms, especially in prostatectomy. Can you kind of explain that to our listeners? Like, why does that happen, especially with prostatectomies?
Well, it's super easy to explain if you've had a radical prostatectomy or a radical cystectomy, because 95% of your semen is made by the accessory organs, the prostate, and the seminal vesicles, and they're removed, right? So it's pretty obvious that I will tell you though, 40% of men who have a prostatectomy don't ever remember being told that they won't ejaculate, right? They come in and say, I don't understand this, right? So it's very easy to understand why with the prostatectomy, with the prostate and seminal vesicles being removed, that men don't ejaculate. Remember that only 5% of semen is sperm, right? And the vas deferens is cut and clipped, ligated, tied off behind the prostate at the time of prostatectomy. So there's no ejaculation. That is not to say that you won't have an orgasm. It's very interesting if you look at ejaculatory distress, right? Men who don't have ejaculation and they're bothered. Of course, as we know, gay men are much more intensely distressed by that than straight men. But 1/3 of our straight men are quite bothered by that. So it's not just gay men. It's actually many men, straight or gay, who have ejaculatory distress. Alongside that, the orgasm quality, at least temporarily, is quite different than it was before surgery.
All right. So another risk of, prostate surgery, pelvic surgery, is something called retrograde ejaculation. So what is retrograde ejaculation, and how common is it in men who, undergo these pelvic surgery?
Yeah, I mean, it wouldn't be an entity in the radical pelvic surgery patients in the sense that they don't produce an ejaculate. But if, for example, retrograde ejaculation, very simply, is that rather than the semen being forced out through the penis, it's going back into the bladder in a retrograde fashion, right? And if the bladder neck, which is under adrenaline control, if the bladder neck is left open, then the semen takes the pathway of least resistance back into the bladder. And the classic group of men who have this problem are the diabetics, right? Because they have nerve trauma down there just from diabetes, right? Especially if their sugar control has not been good for a long period of time. They get retrograde ejaculation. And then if there's anyone on listening to this, looking at this, who has had a retroperitoneal lymph node dissection for testis cancer, those men are also at risk for this, because the fine nerves that supply the bladder neck and cause it to contract and prevent semen going back in, those nerves don't function, and men get the semen takes the pathway of least resistance.
Awesome. And now, just like we talked about for dry orgasms, can retrograde ejaculation impact your orgasm at all?
Yeah, it's very interesting, right? So if you look at orgasm intensity after prostatectomy, the literature's not fantastic, but approximately half of men say my intensity has significantly reduced. When you follow them for 2 years, right? 40% will say, it's definitely different, but the intensity is about the same. But 10% of men will say their intensity is greater.
Interesting. I didn't know that.
This when you're talking to patients. But orgasms are more intense, right? So how then could it be that the absence of semen correlates with orgasmic intensity? Orgasm is a brain event, right? It occurs in the brain, in the pleasure centers of the brain. So there are definitely things that might contribute to orgasmic intensity, semen going through the urethra distending. But most of orgasm is a cerebral phenomenon. Yes, your blood pressure goes up. Your pulse goes up. Muscles contract, right? Those muscular contractions cause semen to squirt out, right? But really, the intensity, the pleasure, is a cerebral phenomenon. So the reasons for having reduced orgasmic intensity after prostatectomy are not very well understood. It's, Captain Kirk, the final frontier in our understanding in the post-prostatectomy patient.
So what about, pelvic surgeries, prostatectomies? Can they impact your libido or your testosterone levels at all? Are these things impacted after you're getting surgery, and then technically going to impact, especially with testosterone, impact things like your libido and other sexual aspects of your life?
Libido is first of all, I think we're trying to move away from the term libido, which is a very Freudian concept, to, the term of sex drive. But it's a very easy thing to talk about. there are three categories of causes of low sex drive, right?
Right.
There's hormones, low testosterone, high prolactin, hypothyroidism, underactive thyroid, right? So what do? We check blood work.
Yeah.
Okay, if they're all normal, then that's not a cause. There are medications, and those medications are classically medications in the psychological disease area, like depression, okay? And there are some other classes of drugs, particularly drugs like finasteride and dutasteride that may interfere with sex drive, propecia or hair loss, etc., no doubt. And then the only other cause besides hormones and meds, psychological. Big umbrella term, right? Big umbrella term under lots of different things under there, including things like I'm worried about my postoperative PSA. I'm worried about me leaking urine at the time of orgasm. I'm worried what my wife thinks about my penis. So anything that distracts us, right? Maslow's hierarchy of special needs, right? Survive, eat, sleep, drink. Anything that distracts us away from sex is going to cause our sex drive to reduce. So most of the men after surgery in my practice who have low sex drive, it's actually because of their ED, right? It's hard for men with good erectile function to understand this, but because you've had particularly you guys, you're super young, you have normal erections all your life, right? But when you start getting erection problems, right, we are only as good as our last erection as a man. And if our last erection isn't good, we have anticipatory anxiety. And that anxiety ultimately leads to avoidance behavior. And that's perceived as low sex drive by the patient and by the partner, right? So this is the classic spiral for men who have ED. And of course, what we do with those patients is confidence restoration. Let's get the man on a drug to give him the best erection possible, support him temporarily.
It's literally the way that we think for everything, pretty much. It's one of those things where, guys, if we get frustrated, we're not doing it well, we're probably just going to put it aside. And then this is the same thing.
Just push it away.
Push it away. Forget
don't think
about it. Just don't think about it.
Let the problem fester,
But that's the problem. Exactly. And that's the thing that's so important here is everything you said, we can get you back. Yes. We talked about a lot of different options for your ED, your libido. There's a lot of things we can look at, and there's a lot of ways we can get you back. But by pushing it aside and not doing anything, like you said yourself, the penis is a muscle. And if we just put it away and we forget about it, there's only so much time we can do to get you back to where you were. But when you come in 5 years later, there's going to be a new baseline, and that return to baseline is going to be different. So the best thing you can do is talk with your urologist.
You brought up something incredibly important that we haven't emphasized yet on the show, and that is there's a time dependence to protecting the muscle. If you go away and you do nothing for a year, and you've had less than perfect nerve sparing and perhaps less than perfect erections before surgery, that's a problem. So really starting the rehabilitation concept early is critical. Remember, biceps, arm in a plaster cast, that kind of concept.
And Dr. Mulhall, not just also the functional aspect, as you've touched on in your papers, it's also the penile length too, right?
Penile volume. So again, the concept of the biceps, right? And that collagen deposition in the penis is permanent. Most men early after surgery don't have collagen deposition. It takes a while for collagen deposition to happen, right? So it's very difficult to diagnose venous leak within the first 2 to 3 months because it takes a while for the muscle to turn from sponge into collagen. So in the early stages after surgery, the nerve trauma causes the penis muscle to be hypercontractile. In medicine, it's called hypertonia. So I don't know if you've ever seen the Seinfeld show, the shrinkage factor where it goes in the
I was in
the pool. So cold and adrenaline, right, causes the muscle to contract. The nerve trauma does the same thing. So early after surgery, it's not uncommon for men to say, I don't know what happened with my penis. My penis is shrunken, but if we grab the penis and gently stretch it, it stretches normally, right? You know that there are many patients who come in who've been told by the surgeon, well, your prostate was this long, and therefore when I took your prostate out, your penis is going to be this much over. That is complete and absolute rubbish. The prostate is removed and the urethra is fixed at a muscle, a layer of muscle in the pelvis, that muscle called the urogenital diaphragm. And it's fixed there. We can't pull the urethra in, we pull the bladder down to the urethra. Okay. So the bottom line is that early changes in length are often temporary, but failure to protect that muscle eventually leads to volume loss.
So guys, basically what he's saying, if you want to keep your penis functioning, you want to keep it the same length, go talk to your doctor, talk to him about your erections, talk to him about your sex life, both before and after you seek any treatment for cancer, especially prostate cancer, And the thing is, sometimes and many times that guy, that surgeon, guy or girl, who's doing your prostatectomy may be a different specialist in the field for exactly the things we're talking about. I'm not going to be doing prostatectomies. Dr. Chu might be, Kevin might be, but I know Dr. Mulhall is not doing prostatectomies, but he's at Sloan Kettering and he's treating all those guys who are getting prostatectomies or plan on getting prostatectomies.
Right. Can we talk a little bit about sexual incontinence?
Yeah, sure.
Please. Oh. So this is a relatively new, we've known about it for many years, but it's getting a lot of attention now. So the concept that men leak urine during sex. So their erections are fine, their penis is straight, but every time they start getting aroused, their wife gives them a massage or she's cuddling him before sex, they start dripping urine. Or that's called arousal incontinence. Or at the time of orgasm, at the time of climax, they ejaculate urine. That's called climacturia. Yeah. So if you look at climacturia, which for many men is quite distressing, many partners is quite distressing, right? 60% of men have climacturia on at least one occasion after surgery, and about 20% of men have it consistently throughout the first year, and it usually gets better in the second and is much less common in the third year. We tell our patients, in the first 6 orgasms after surgery, we'd like you to avoid oral sex. We'd like you to have a towel on the bed and see if you ejaculate urine. Oh. If it's going to happen, it's going to happen in that time frame. If you don't have climacturia within those first half dozen orgasms or so, it's very unlikely it's going to happen after that. But this is something that is very startling to patients if they haven't been forewarned about it. You can understand that. And if there are women listening, urine is not toxic. If you get exposed to urine, it's not going to cause UTIs or yeast infections. In fact, the woman's vagina is exposed to urine every day of her life as she sits on the toilet bowl. The vagina is a very hardy organ, right? But it's aesthetically displeasing for many couples.
Right. Yeah, of course. I think that's a very, very interesting point. And it's something, like you said, is not being talked about enough. And especially a lot of people aren't expecting that when they're, you're stressed out, you're starting to get back into sexual activity, and the first thing you see is pee, probably may take you out of.
It's a bit distressing. It's a bit distressing.
Yeah, it's a bit distressing.
So, Doctor,
I think one of the important messages on the show now, this show, is to communicate to patients. You want to go into your surgeon. I know your cancer is super important. Almost certainly that's going to be cured, right? But if sexual function is important to you, right, you want to go in with a list of questions that you and your partner, if you have one, want answered. Okay? You have to have those questions at the ready. So, for example, every patient that I see before surgery gets the same talk, all right? That you won't ejaculate. You should have an orgasm. It might be different in quality, at least early on. There's a 15% chance of orgasmic pain. Okay, muscle spasm phenomenon. There's a 60% chance of having orgasm-associated urine leak on at least one occasion. And then we move into the first phase of rehab, 2 weeks before surgery in our practice, the 6 weeks after surgery. Okay, that's the first phase of rehab. And that's all we tell them to do. The first phase, and we'll see you 6 weeks after surgery, and we'll figure out what the next step is after that. So they're the messages that people should have in their mind if sex life is important to them.
I think that's great. That was
really well.
And I think that's a good way to wrap this up. I mean, any final comments, concerns, or thoughts by either one of you guys?
That we have to be wary of obsessive oncocentricity, which is a big fancy medical way of saying that cancer doctors are very focused on your PSA. Understandably, of course. That's what they're there to do, cure your cancer. So you can't always rely on your surgeon to give you the best advice about what to do after surgery if you've got sexual problems. And seeking out somebody who has specialization, like you two guys and me, is very important. Declare how important yours, even if it's in the pre-op area. As the surgeon's getting ready, we're going to take you back soon. Don't forget, Dr. Jones. Right?
Yeah. It's and during residency, right before these surgeries, I do remember those patients. I remember those patients in the preoperative area saying like, listen, we need to preserve my erections.
Save
those nerves. You have the partner right next to them right before saying goodbye, saying, save those nerves because, we want to have a good sex life together. And that's important. And I think it's a great message, and it's really important to think about. And guys just have to be vocal about it, like you said, which is sometimes harder for a lot of guys to talk about than they'd like to admit. All right.
I mean, that's why we're doing the show, right, Justin? Yeah. Try to get the info out so that way guys know about it. It's okay to talk about it and be vocal to your doctor, So.
Absolutely, for sure. So I think that's a great way to wrap it up. I want to thank you again, Dr. Mulhall, for joining us. This was really informative. This was really awesome. I think this is going to really empower a lot of guys to, take better control of their sex lives, both once they get their diagnosis of cancer, before they get their treatments, and then afterwards as well. So really appreciate you coming on. All right. So just to wrap it up, any questions, comments, concerns, please feel free to reach out to Kevin or I on our social media accounts on Twitter, Instagram. We're on TikTok, The Man Up Pod. You can find us there. You can also find us on our website. What's our website, Kev?
It is www.themanuppod.com.
You can listen to this podcast on Spotify, iTunes. Give us a review, comment. 5 stars is always appreciated. You can also watch us on YouTube. Subscribe there as well. For Kevin and Dr. Mulhall, thanks for listening. Until next time, have a good one.